So the NMDA receptor, sort of diving more into what the NMDA receptor is all about and why this is such a special receptor and why it's involved in so many different disease states. So it is a unique receptor in the sense that it's an excitatory receptor. It's a glutamate receptor. So when NMDA is activated, you see some excitatory neurotransmitters that are released, such as glutamate and glycine. It's present in all neurons in the central nervous system, specifically in the dorsal column of the spinal cord. It's highly permeable to sodium and calcium into the cell, and then potassium out of the cell. Magnesium, which, as you know, magnesium has been used for pain, and sometimes when people have low magnesium, they have pain. There's some peripheral reasons for that, but there's also a central reason for that. NMDA is one of the receptors for magnesium. NMDA signaling is very important in anesthesia. So we have seen this multiple times. We've seen this with neuroplastic changes. We've seen this with pain processing and the generation of central sensitization. So studies have been out for many, many years, and we've seen this anecdotally as well, that when we use ketamine intraoperatively with our anesthetics, we actually see a lower utilization of opioids after the surgery. We actually also see a lower pain score after the surgery. And some of the data, even from 15, 20 years ago, they didn't really know why. Some of the data where they used ketamine with propofol for surgeries, they sort of had this like happiness score, and they said, wow, patients are more happy after that. But they didn't really know why. But it was really due to this sort of NMDA blocking property, where if you didn't allow the brain to become sensitized to the injury, which was the surgery. Remember, just because you're unconscious doesn't mean that your brain is not perceiving these signals. We all know that. As anesthesiologists, we know that, right? If you could be anesthetized, but once that cut happens, the heart rate, blood pressure, everything starts going up, okay? So just because a patient's unconscious doesn't mean they don't feel anything. So if you can prevent that coupling of the injury to the experience, the unconscious experience, you're not going to have the same response postoperatively when the patient is awake. The NMDA receptor is very important, like we said, with neuroplasticity and synaptic neuroplasticity, as well as memory function. Aberrant NMDA receptor activity leads to memory dysfunction. You guys have all heard of this drug called Namenda, right? Namenda. So Namenda is actually a play on letters. Namenda is really a play on NMDA with vowels stuck in. And Namenda is FDA approved for memory. But different receptor, different subreceptor, which we'll kind of talk about in a minute. This is the NMDA receptor. So if you can see there's so many different things that bind to it and so many subreceptors of NMDA. And that is why not all NMDA receptor antagonists work the same. So, there are tons of things out there. You say, oh, well, this is an NMDA receptor antagonist, and this is, and this, and this, and why can't we just use them all interchangeably? And it doesn't really work that way. So just remember that, right? So there are some drugs that are not legal, and they're NMDA receptor antagonists, and some people out there may say, well, gee, we should legalize those, and we should just use those like water. And it's like, no, guys, listen. There's different efficacy and different safety with every single product, okay? So just because they bind to a subreceptor of a main receptor doesn't mean they're all the same in terms of efficacy and safety, because those are the two big things we always have to worry about. So you have these subreceptors can be numerous, and I won't go over all of them, but there are a ton of subreceptors. Like we said in the very beginning, remember we said that it not only binds to NMDA, but you may see this gene activation in central sensitization. Well, ketamine has also been shown to result in suppression of immediate gene expression at the site of injury. So when we have the central sensitization, we see this gene activation, which is causing these neuronal changes. Well, we have this drug now, which for whatever reason, amazingly, is not only binding to the receptor that might be the problem, but it's also suppressing some of this early gene activation that we know causes some of these, sort of pro-inflammatory responses, which then result in a cascade of events, which obviously the body then remembers that experience. Ketamine alters the regulation of NMDA receptor phosphorylation, and you also see ketamine limiting astrocytic and microglial activation. Remember at the very beginning we talked about central sensitization as being microglial activation? Wow, now we have this molecule that actually we've seen evidence where it suppresses microglial activation. How crazy, right? Like we're checking off all of these things that we know are a problem with central sensitization when it forms. When you're using ketamine at clinically at clinical doses, it affects a wide range of cellular processes, and this can be, again, the blockade of NMDA, suppression of certain gene activation, blocking certain neuronal hyperpolarization, activated cationic currents, looking at the nicotinic acetylcholine ion channels, potentially even blocking, or not even blocking, really more resensitizing delta and mu receptors.